So, Pisotriquetral injuries by Hannah Rammel. The anatomy. So, this deals with the pisiform, the triquetrum, the pisotriquetral joint, which is where the pisiform and the triquetrum articulate, the ulnar collateral ligament, the pisotriquetral space, which is the space right here in between the pisiform and the triquetrum, and the flexor carpi ulnaris, which is the muscle that runs down into the hand that inserts by the pisiform and the triquetrum. Pathology. It is usually a chronic injury. It's usually mainly from arthritis. This is also can be caused from the dysfunction of the pisotriquetral joint, also tendinitis of the flexor carpi ulnaris, or osteoporosis in the pisiform or the triquetrum. And over to the right, we have a picture of osteoarthritis in the pisiform, and this is an x-ray. So for mechanism of injury, it is usually caused by a pisiform subluxation, an acute trauma, a chronic trauma, some type of instability, or fushing in the case of a dislocation or a fracture. Up in the top right, you will see a pisiform subluxation. I know the picture is not totally great, but it shows you what the hand would look like on the surface, and then it also gives you x-ray views of the hand, and also gives you a lateral view of the hand. And then down on the bottom, that would be a fracture of the triquetrum. So, signs and symptoms. For pisotriquetral injuries, you would have some type of pain, usually over the pisotriquetral joint, or on the ulnar side of your hand near the joint, tenderness, grinding over the joint, some type of instability, edema, an obvious visual deformity if it's a fracture, a dislocation, a possible subluxation. If it's on the chronic side, they usually have a strange or unusual carrying of the hand, or possible crepitus when you feel it. So for special tests, you can do x-ray, you can do the grind test, which is to rule out the arthritic pain in the joint, and then I'm going to show you a thumb grind test, but it can be done on many joints. This is just going to show you the one that's done on the thumb since it is the most common. In endoscopy, which is basically an exploratory surgery done, you can do them on any kind of body part, but this would usually be done in the hand, an MRI, or a CT scan. Okay, so predisposing factors would be arthritis in the joint or mostly anywhere in the hand, any kind of prior fracture to your pisiform or your triquetrum, any kind of past surgeries near those two bones or laxity of your muscles or tendons. This is your flexor carpi ulnaris. You can see where the insertion points are. So laxity would cause overcompensation by other things to cause pain in the ulnar side of your hand. So for recognition and differential diagnosis, we have arthritis, osteoarthritis, which is different than arthritis as it is just bone arthritis. Flexor carpi ulnaris injuries such as laxity, sprains, strains, tendinitis, or fractures of the bones. Tendinitis is shown over here. It just shows you what tendons are in the wrist and where they go out to. As you can see on the ulnar side, there are at least 2 tendons that run near the bones that we are talking about that could cause some inflammation and problems. So for management and treatment, you have steroid injections into the area near your pisotriquetral joint, NSAIDs, protective splints, possible therapy and surgery. And the one that I have over to the right is called pisiform excision, which is basically where they go in and take out your pisiform. And then that picture just is a picture of it, and your pisiform is sitting down there. So for referral and immobilization, you would refer them to an orthopedic specialist, and then they would go from there with a protective splinting, protective bracing, or possible casting if a fracture is possible. Down on the far left, you have the protective splint, which usually includes a metal bar that runs up through the wrist to hold it. In the middle, you have a wrist protective brace. This would be if they're having issues, but they're still being allowed to play. This will help protect the wrist. And then all the way to the right, you have a wrist cast, which is full immobilization of the wrist. And for prevention, you would do proper falling techniques, so being taught the proper way to fall if you're doing something that could potentially lead to a lot of falling, and being careful when playing contact sports. So for Mulligan, there are 4 different Mulligans that I found for this type of injury. So for the posterior glide, this is all for the right hand. In order to do the left hand, you would just switch your hands. And that's, yeah. So for the posterior glide, you would have the patient put their arm on the table with their palm down. The examiner would place their left fingers on the volar surface of their pisiform and triquetrum, while their thumb is on the dorsal surface in the same area. The examiner's right hand would also be on the distal forearm in the straight fist position, as you can see in the picture above, in the ulnar surface. And then you would take the thenar eminence and push downward or anteriorly on the radius and ulna, and mobilizing the pisiform and triquetrum dorsally. And then that picture up in the top right is just a picture of somebody doing this mobilization. Okay, and for anterior glide of the right hand, the patient would place their arm on the table, palm down. The examiner would take their right hand and hold the distal forearm in a straight fist position around the ulnar surface, with the dorsal surface of the fingers resting on the table. The examiner would also take their left hand and put it in contact with the triquetrum dorsally, as the left index finger touches the triquetrum and the pisiform volarly. And then you would take the left thumb and push the triquetrum anteriorly. So for the lateral/radial glide of the right hand, the patient with their forearm resting, palm down on the table, you would take elevation by a wedge or a rolled towel under their distal forearm. The examiner would place their left hand holding their distal forearm in a palm down manner. The examiner's right hand first web, which is the space in between your first phalange and your second phalange, would place it on the patient's triquetrum and the pisiform and palm down manner, while the fingers and thumbs support the hand dorsally and volarly. The examiner's right hand pushes proximal row in the radial direction, arching in a concave manner in relation to the distal ulna and radius. So for the medial and ulnar glide of the right hand, the patient takes their resting forearm and puts it on the table in a neutral position. We then place a wedge or a rolled towel to elevate their distal forearm, and then the examiner places their left hand on the distal forearm and wrist with the first web space touching the ulnar aspect of the triquetrum. Then the examiner places their right hand first web to touch the patient's radial aspect of the distal row over the trapezium and the finger to support the patient's hand. The examiner's right hand pulls the ulnar direction, arching in a concave manner in relation to the proximal row. And there are my references. And there is the peacock, along with the reference at the bottom.